Welcome to this conference. I'm very thankful that so many have managed to attend, especially those sufferers who find it very difficult to travel. This conference has been arranged in order to give both sufferers and those in the medical and legal profession a further insight into the effects of myelography whereby myodil was used. Dr. Burton will be lecturing especially upon the diagnosis, treatment and screening techniques of lumbar adhesive arachnoiditis, and I would be very grateful if any questions put to Dr. Burton either during or at the end of his lecture will be strictly of a medical nature. Dr. Burton's great desire to educate people about arachnoiditis is astounding, especially when so many other doctors avoid the topic. I feel honored to have him here. I would like to thank everybody who has sent me donations and has helped me to set this medical conference up. Thank you, Pat, Bert, and Maureen. As we haven't quite reached the target for the amount of money necessary to pay for everything, I thought I'd leave a collection box. If anybody would like to make a small donation, it will be much appreciated. I now have the pleasure, ladies and gentlemen, to introduce to you Dr. Burton. Please give Dr. Burton a warm welcome.
Thank you, Ms. Coxhead. Good afternoon, everybody. This is a subject that people do not wish to discuss. So let's be very candid about it. Let's start out by pointing out the fact that throughout the world, there are subjects that people in various environments particularly do not wish to discuss. And it seems to me that in the UK, the toxicity and disability of myodil is particularly a subject that falls under that category. We will be exploring what is known from a medical standpoint regarding the subject. Does adhesive arachnoiditis exist? Yes, it does. Is it a disease? Yes, it is. Is it common? No, fortunately, it's not common, but it can be devastating, as many of you in the audience know. Is it a clinical problem? It very often is a clinical problem. However, the question is, does arachnoiditis exist? Arachnoiditis exists also. Is it common? Arachnoiditis is a very common entity. Probably everybody you see and pass on the street has arachnoiditis, because arachnoiditis only means inflammation of the arachnoid. It can occur from a simple injury, a simple fall. Every person who has had any operative procedure on the spine has arachnoiditis. Now, by arachnoiditis, it can be very simple. It can be arachnoidal adhesions. It can be so simple that it cannot even be picked up by present imaging studies. But the entity arachnoiditis is common. Is it a clinical problem? Typically, it is not. So in all fairness, I think from the standpoint of definition, what we're here to talk about today is not the common entity arachnoiditis. We're here to talk about adhesive arachnoiditis, which is not common and which can be a very cruel disease. The spectrum of arachnoiditis, therefore, is something as simple as arachnoid adhesions, which are very common, but also typically not associated with any clinical signs or symptoms. Local arachnoiditis, which very often is seen following injury. We see a lot of patients who've had seatbelt injuries or motor vehicle accidents who have sustained traumatic local or focal arachnoiditis, which can be adhesive arachnoiditis. But again, what we are really focusing on and discussing today is the entity adhesive arachnoiditis, which can be broken down into various classes, mild, moderate, and severe. So from the standpoint of discussing this, it's really important to appreciate the fact that nomenclature and terminology and common understanding of that is essential. We have been dealing with the Tower of Babel in regard to this issue for a long period of time. I have seen conversations where one person is asking questions and has in their mind one thing, and someone else is answering the questions and has in their mind something else. Now, I don't know how many of you are familiar with Abbott and Costello, who were comedians in the United States, or their famous routine called Who's On First, but that's a perfect example of a failure to communicate. If you don't remember, the first baseman's name was Who. The second baseman's name was I don't know. And it led to a very interesting situation. Well, a lot of what has gone on in the past has been basically a Tower of Babel, or in the American terms, who's on first. Secondarily, various people have looked at the issue in different ways. Some have looked at it from the standpoint of the radiologist, whose only involvement is to do a diagnostic study, and if he gets pretty pictures, he's happy. That's his only involvement. So again, part of the problem is not only nomenclature, but it's really been various individuals describing the elephant or the entity of adhesive arachnoiditis and only having access to one small piece of the puzzle. So part of what Ms. Coxhead has asked me to do today is to try and put more pieces of this puzzle together, enough pieces so we can see what the image is on the puzzle, even though we don't have all of the pieces yet. But I think you'd be astonished how many of the pieces that we do have. Now, why am I here, or why are we doing this thing? That's a good question. I've asked myself that a lot, and I'm sure Ursula Coxhead has asked herself that, and I'm sure many people who are here today have said, why do I stick with this despite the adversity? And the level of adversity is very high. This is the emblem for my undergraduate school, which was Johns Hopkins in Baltimore, in Maryland. The motto of Johns Hopkins is Veritas Vos Liberabat, the truth shall set you free. And I have always been hung up on that. I've never gotten over that exposure. I do believe in it, and I think truth is important. So one of the reasons that we're doing this is truth, pure and simple. I'd like to point out that the crest of Johns Hopkins, which is also the crest of the state of Maryland, is the crest of the John Carroll of Carrollton family, who founded the state of Maryland before the Revolutionary War, but we won't get into that. We have enough controversy here today. Another reason for being here is the simple fact that we can only improve the future by studying the past. We can only improve on what we do in the future by acknowledging and understanding where we have failed in the past. Even though oil myelography, Myodil in Europe, Pantotake in the United States, has decreased dramatically, even though there is some evidence that it's being used elsewhere in the world. Essentially, in Europe and the United States, one does not see oil myelography anymore. One does continue to see circumstances where toxic agents are being introduced into the subarachnoid space. So an understanding of this subject does have importance for the future in regard to preventing other individuals from being subject to problems that many of you seated here today have experienced personally. So it is not a moot issue. Some people have said, well, we don't use oil myelography anymore. Who cares? That's not true. There is reason to care. The primary anatomic structure that relates to our being here, that relates to arachnoiditis, that relates to adhesive arachnoiditis is the arachnoid space. And very few people in medicine really understand what the arachnoid space is. So let's look at this illustration from Gray's Anatomy textbook, which is the one I had in medical school. I'm not going to tell you how long ago. But the subarachnoid space is outlined in yellow. This is a drawing of the brain, not the spinal cord. Now here is the brain. Here is a membrane called the pia mater, which in Latin means little mother. On the outside is the thickened dura, or dura mater, which I believe says, or is interpreted in Latin as thick mother. And here is the arachnoid membrane, which is a very thin membrane. The pia is actually thinner and more fragile. And running between these two fine filamentous membranes are little extensions, trabeculi, of the arachnoid. The dura, because it is very thick, is referred to as the pachymeninges. The arachnoid and the pia are referred to as the leptomeninges. It is through the subarachnoid space that spinal fluid circulates. The spinal fluid is formed in the spinal subarachnoid area. It circulates up the body. It bathes the brain and the brainstem and the cerebellum, and it's absorbed into the venous system through these villi called arachnoid villi in the brain. Now, in the spinal area, there are no arachnoid villi. But the arachnoid membrane is a very dynamic membrane. It's very busy. It is producing spinal fluid all the time. It is not just sitting there minding its own business waiting for somebody to have a myelogram. Myelography is a study. It's a means of obtaining diagnostic information. To do or to perform a myelogram, one must enter into the subarachnoid space, and typically with a needle. This shows a needle being introduced into the subarachnoid space for the purpose of myelography. Over here is a picture of a Pantope or oil myelogram. One can see that it outlines the subarachnoid space in the lumbar area. Actually, it doesn't do a very good job of outlining the subarachnoid space in the lumbar area because oil is highly viscous. So it doesn't fill all the fine crannies and nooks of the subarachnoid space. This is a water-soluble contrast myelogram. Water-soluble substances have low viscosity. They fill out the space much better and define the space much better. So if a clinician who desired a patient to have a myelogram wanted the best information in myelography would be provided by a water-soluble contrast agent. Even so, this happens to be an excellent water-soluble contrast myelogram, but even so, the myelogram does not clearly show these structures lateral to the subarachnoid space, and as we will see later, it's incomplete information, but it is information. This is a picture of a neurosurgeon by the name of Walter Dandy. Walter Dandy was the second professor of neurosurgery at Johns Hopkins, the first professor having been Harvey Cushing. It was Walter Dandy who was the pioneer in the United States of myelography. It appeared to Walter Dandy that if air could be injected through a needle into the subarachnoid space in the lumbar area, a radiologist could then see the outline of the subarachnoid space. So he was the one who introduced air myelography. Air myelography was very, very difficult for the radiologist. The radiologist could not see the air very well. You couldn't control the air very well. And if the air got into the head, it could cause severe headache, nausea, vomiting, and it wasn't a pleasant study for the patient. Now this is while the radiologist is involved. This is at the front end, okay? The pioneers of myelography are listed in this slide. And let's look at who the pioneers of myelography were and what it was that they introduced into the subarachnoid space in the spine for the purpose of myelography, okay? Let's start out in 1921 with Dr. Dandy with air myelography. Now of interest, Drs. Bingle, Jacobius, and Wilderow in Europe at the same time were also introducing air myelography. So it clearly was a thought that occurred to a number of people at the same time. Throughout history, one sees examples of this. Everybody knows that Charles Lindbergh was the first to fly from New York to Paris nonstop. Not many people know that there were 12 other pilots who would have done it within the next 24 hours and all set up to do it. Because again, it was a thought that occurred at a certain time when technology and need came together. So clearly, there was a unanimous, no, nothing's unanimous, there was a high level of desire for more information of the spinal canal, the subarachnoid space. In 1922, Sicard and Forestier introduced iodinized poppy seed oil. This was called Lipiodol. And they took poppy seed oil, iodinated it, and introduced it into the subarachnoid space. No one seems to question today the fact but that this was very toxic. This was a very toxic foreign body in the subarachnoid space. I will not belabor the point, but there is a great deal of literature by very concerned physicians during this period of time regarding Lipiodol. In 1928, Fraser and Glasser attempted to develop something less toxic, and they introduced iodinized rape seed oil, Campiodol, which also was toxic. It was not shown to be better than Lipiodol and did not have use for a very long period of time. The next pioneering effort was that of Wustman in 1933, who introduced thorium dioxide thorotrast. Now, thorotrast was a water-soluble contrast agent. It gave beautiful pictures. The radiologists were enthralled. Unfortunately, thorotrast was radioactive. And we will look at it in greater detail. But in 1933, you'll say, gee, not many people appreciated the risks of using radioactive substances in the body. Well, not so. If you look at the literature, the fact that thorotrast was radioactive and was being used in the human body was a matter of great concern to a number of people. But somehow that concern never got across because many people received thorotrast myelograms. These people, many of whom, years later, developed adhesive arachnoiditis, myelopathy, degeneration of the spinal cord, and malignant tumors of the spine and the brain showing up 10 to 20 years later. Now, how many thorotrast myelograms were done? No one knows. What percentage of people who had thorotrast developed adhesive arachnoiditis? No one knows. What percentage developed myelopathy? No one knows. How many of these people developed malignant tumors of the brain and spinal cord? No one knows. Because this information was never made available to the people doing thorotrast myelography for their patients. Thorotrast was an excellent myelographic material for the radiologist. There were no problems from the radiologist standpoint. The pictures were excellent. The fact that it was a radioactive material containing thorium was not felt to be important because it was thought that it was excreted from the body very rapidly. That was not found to be true. The thorium dioxide would become absorbed into the arachnoid membrane and stay there. It was not significantly eliminated from the human body. Thorium is a potent alpha particle emitter. It has a half-life of 1.4 times 10 to 10 years. Body elimination is negligible. The tissue radiation range is 30 to 50 microns. So the subarachnoid space had constant radiation from this radioactive substance. The complications of thorium dioxide were never really identified until the 1950s and the 1960s. And that was really too late for the people who had these complications. And even though none of this was acknowledged, people caught on to the fact that thorium dioxide, thorotrast, wasn't the best thing to use. So we moved on. Thorotrast was clearly a toxic substance. Detergents represent another very interesting phase of the story because before the advent of using disposable needles and syringes, hospitals used to reuse the needles and the syringes. How many people here remember when needles were reused? Okay. Now, to reuse them, you had to wash them. And in the United States, in the 1950s particularly, there was an outbreak of individuals having lumbar punctures and myelograms who became paraplegic. Almost immediately following this needle placement. And what they found was that the paralysis was due to neurotoxicity of detergents that were being used to wash out the syringes and the needles. So minute amounts of detergent was found to be causing paraplegia. Another indication of the fact that the subarachnoid space is very sensitive to foreign body substances. Because of the number of patients who became paralyzed from this, and it was mainly not for myelography, it was mainly being used for spinal anesthesia in those days. Spinal anesthesia developed a very bad name, which it didn't deserve, because once disposable needles and syringes came into use, this problem went away. But in the United States today, medical malpractice insurance, as you know, is quite high, and your medical malpractice insurance is a lot higher if you indicate the fact that you do spinal puncture for spinal anesthesia. And this is just a carryover of an experience that was many decades ago and no longer being seen. But from the standpoint of why we're here today, it's an important piece of information. Along then came oil-based contrast agents, lopiodol, then pantopate and myadil, and more recently, depomedrol. That's what it's called in the United States. I think here it's depomedrone. Okay. I believe it's the same material exactly, with just a different name, as is basically pantopate and myadil. They are both iophendylate, but with different names. But in my practice, depomedrol is now the bad actor. Depomedrol being placed in the subarachnoid space is the primary reason that people today in my practice are developing clinically significant adhesive arachnoiditis. For many, 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 many years, pantopate was the primary reason that patients were being seen at the Institute for Low Back Care in Minneapolis with intractable pain and neurologic deficit. So basically, what we're saying is that all of these substances have neurotoxicity. They are all toxic substances. The only difference is the degree of toxicity, whether the toxicity is acute or chronic. In today's world, the primary cause of clinically significant adhesive arachnoiditis is depomedrol. So it is important today to understand the subject. It is important today to go back and view the past. It is important for people like Ursula and myself to be what Dr. KW has said, not smart enough to know when to quit. What is depomedrol or depomedrone? Well, it's a gamish. A gamish is a mixture of substances. And very frankly, most of the substances that we're talking about are gamishes. They're mixtures. The primary ingredient in depomedrol is methylprednisolone acetate, a steroid. And people say, well, gosh, you treat toxic reactions with steroids. Why would depomedrol be a problem? Well, it's typically not a problem because of the steroid. It's a problem because of the other substances in the gamish, and particularly polyethylene glycol has been identified as being toxic in the subarachnoid space. That brings us to the question now of water-soluble contrast agents. I was at a meeting of the International Society for Study of the Lumbar Spine a year ago, and a very prominent physician from London came up to me and he said, Chuck, do you know that people are saying in London, they're quoting you as having said that people can get arachnoiditis from water-soluble contrast myelography? He said, can you believe that? I said, yes, I believe that. I said, it's true. And he said, well, where was